Good afternoon, everybody, and welcome to the webinar. I am Andrea Baer, the Executive Director here at Mended Hearts, and we are in session 3 of our Beyond the Numbers cholesterol series. It's a lipid control webinar series that is built upon last year's Beyond the Numbers. So today's topic is Beyond Total Cholesterol, Understanding Your Lipid Panel. And before I get started with the presentation, I just wanted to give a shout out to all 3 of the organizations who are partnering together to bring this series to you. Mended Hearts, whose mission is to inspire hope and improve the quality of life of heart patients and their families through ongoing peer-to-peer support, education, and advocacy. The National Lipid Association's mission is to enhance the practice of lipid management in clinical medicine, and the foundation of the NLA, whose mission is to improve the welfare of patients and families affected by cholesterol and triglyceride problems. So before we get started, I just want to give a couple of announcements. All attendees are in listen-only mode. If you cannot hear, check the audio button. Hopefully you can see the slides if you can't hear me. On your personal computer to make sure your sound is on. That's typically the main problem that we see, on the webinars. Please type your questions into the Q&A box at any time during the presentation. The Q&A box should be located down in your little toolbox, and the questions will be read and answered after the presentation is over. As a note, the presenter will not be able to answer questions about you specifically or about your child, as he or she is not the treating physician. The PDF version of the slides, as well as a recording of this presentation, will be available on the Mended Hearts website following the event. So to introduce our speakers today, I'm so excited to welcome Dr. Catherine McNeil. She is the Associate Professor of Internal Medicine and the Associate Professor of Pediatrics, Texas A&M University System Health Science Center College of Medicine, with the Division of Cardiology at Baylor Scott and White Health in Temple, Texas. And representing the patient voice today, we have Mandy Sandkohler. And Mandy is actually one of our staff members, so a lot of you may know her. But what you might not know is that her family actually has high cholesterol issues, and her children, as young children, do have high cholesterol. So Mandy was really interested in being a part of this presentation, and so we were very thankful to have her. Just as an advance, she is joining us on vacation in a remote cabin in North Carolina, so she's not able to show her video, but I'm so excited to have her here. So thank you both for joining us today. I would love to get started with a poll. So we're going to do a poll just to test your knowledge. And I'm going to launch this poll, and I want to see what you know about lipoprotein-A. So here is the poll. So you have to answer the question. It's like LDL cholesterol. It is greatly affected by your diet. It is primarily inherited from your parents. It's like HDL cholesterol. It is a good lipid, or not sure. I don't know what a lipid protein A is. And I'm just going to give you a couple more seconds for everybody to jump into the poll and answer what you think is the right answer. And I am sure that Dr. McNeil will be giving us the answer during her presentation today. All right, I think we've got a majority of votes in. So I am going to go ahead and end the polling and share the results. And this is tricky, Dr. McNeil. It looks like we don't really know, a lot of us, right?
Great, great.
Excited to learn.
Are you gonna repeat it at the end?
I think we are going to repeat it at the end, yes. So, all right. So with that, I am going to turn over the remote to you, Dr. McNeil, and hopefully we will do this seamlessly. and you will have control of my computer.
Okay. All right. So thank you, Andrea. It's a pleasure to be here today. Our local Mended Hearts organization is just a terrific asset to our community. So I want to give you guys a real shout out. Of course, the National Lipid Association and the FH Foundation have just done a tremendous job provider and patient education and advocacy. So all three organizations, real terrific shout out to you guys. So my task today is to talk about how to interpret a lipid panel, what LDL cholesterol is, what lipoprotein-A is, and just a short overview. Sometimes physicians, providers will order what's called an advanced lipoprotein analysis, so I'll do that. And Andrea, I'm not getting control here. Okay, all right. You may have to advance the slides for me because it's for some reason not letting me. Is that okay?
Yeah, absolutely. No problem.
Okay. All right, next. So the question I want to ask to the audience is, what do you think would happen to cardiologists if no one developed hardening of the arteries? That's what the old timers called atherosclerosis, or all of these terms really essentially refer to the same disease, which is that very gradual buildup of cholesterol plaque in the arteries. Next. I'm going to use the term coronary heart disease here, but again, any of those terms on the previous slide apply. So coronary heart disease is caused by this very, very gradual buildup of cholesterol plaques in the heart arteries and not in the veins. I always want to emphasize that with my patients. So remember, veins are blue and arteries are what you can feel but not see. So arteries carry the blood that nourishes the heart muscle, and those cholesterol deposits in the arteries can slow down or decrease the flow of blood in the arteries, leading to that chest pain that is referred to as angina. I want to just add that sometimes in women, we don't have that sort of classic symptom of the elephant sitting on our chest. Sometimes in women, angina is a greater sense of increased fatigue and unusual shortness of breath. So this prolonged absence of blood flow or decreased blood flow to the heart muscle is what a heart attack is. And that can leave a scar in the heart if it is severe enough. That is a true ST segment elevation, myocardial infarction, okay, a STEMI you may hear. Sometimes doctors refer to an NSTEMI, so non-ST segment elevation, myocardial infarction, where just the blood test for a heart attack is elevated, but we don't see the EKG changes. Now, a lot of times if you have coronary heart disease, if you have the buildup of plaque in the heart arteries, it can also occur and be present in the neck arteries or the leg arteries. So strokes can be caused from many problems, including aneurysms, irregular heartbeats, hypertension, but one is the very gradual buildup of fat in the neck arteries, and blockages in the leg arteries that essentially cause angina of the legs is what peripheral arterial disease or peripheral vascular disease is. Next. So when we refer to these plaques, what are they and how do they form? So I've already told you that they refer to this very gradual buildup of cholesterol, of fat in the artery walls. And there's a schematic in just a minute. So your heart arteries really are about as big around as the tip of this ballpoint pen, and your neck arteries are about that big around. So it doesn't take a lot of cholesterol to cause that blockage. As I had mentioned, these blockages can occur in many arteries, but they really are essential precursors to having a heart attack. Now, there are some very unusual reasons for heart attacks, like cocaine, but the most common one is this very gradual and slow buildup of fat in the arteries. Next. So here's the schematic I promised you. And one of the things I do want to emphasize, I guess I don't, oh, I do have a pointer. Can you see the pointer on the screen, Andrea, if I use my pointer?
No, unfortunately, we cannot.
Okay, all right, okay. So what I want to emphasize with this is, so you see that there is this very gradual buildup of cholesterol over many years. And it is not until the very end of this process that we actually see that the narrowing of the artery occurs. So the first thing that happens is actually sort of this buildup of cholesterol occurs external to the blood flow. And it is not really until late in the disease, when people are starting to have symptoms, that there is the narrowing of the heart arteries. And you can see this debris of cholesterol cells, and there are all sorts of other cells. The vascular biology of this cholesterol buildup is quite complex, but after many, many decades of study, actually quite well known. One of the things I also want to point out that you don't quite see in this schematic is that your arteries are lined almost with an impenetrable barrier called the endothelium. And a healthy endothelium really helps prevent the cholesterol deposits in the arteries. Good, healthy diet, exercise, and control of all risk factors helps that endothelial surface be less vulnerable to penetration of these LDL particles that you see on the schematic. Next, please. So we're going to talk about what risk factors are for atherosclerotic cardiovascular disease, but I want to emphasize these are not additive. They are multiplicative. So that is why having one is not quite so bad, okay, but 2 or 3 can really fuel the fire for a heart attack in the future. Next, please. So here are what have always been classified as major risk factors for atherosclerosis. You're going to see that I'm interchanging these terms all the time, and that's because partly I want to keep you on your toes, but also because you'll hear them differently. So the major risk factors for this buildup of plaque in the arteries is a high LDL cholesterol, a low HDL cholesterol, hypertension or high blood pressure, diabetes, be it type 1 or type 2, tobacco use. Men get heart disease earlier than women, and almost everybody gets a little bit of heart disease as we age. So it's kind of normal for our arteries to age and have some cholesterol buildup. Next, please. There are a whole host of other risk factors that are thought to be emerging or minor risk factors, but one of the ones we're going to talk about today that really is probably moving more into a major risk factor is lipoprotein-A. We'll talk a little bit about what apolipoprotein B is. It's just another way essentially of reflecting the LDL in the bloodstream. But a host of many others, and some are just risk factors. A multiplicative effect of minor risk factors are, probably even some we don't know yet, and which will be characterized by emerging research. Next, please. Okay, so everybody's heard that cholesterol is good for you, and this gentleman probably has a little bit of the wrong effect. He thinks it causes clogs in the veins. Well, you already know that that's not, it happens in the arteries, right? So he thinks it helps reduces bleeding risk. Next, please. One of my friends once asked me what cholesterol is, and I'm a chemist by training, so I just replied, well, it's got 27 carbon atoms, 45 hydrogen atoms, and a hydroxyl group to it. And she went, yikes. Cholesterol is one of the 2 types of fats in the blood. We all need cholesterol. Actually, because cholesterol is so essential for our health, every cell in our body makes cholesterol. That's why some people who are born without any cholesterol can do perfectly fine because every cell makes it. So there's two sources of cholesterol. Some of it comes from the food we eat, and some of it is made by the liver. Now, both the good and bad cholesterol come from foods we eat, and both, although I hate that term good and bad, but healthy and heavenly or lousy and lethal, those fats, that cholesterol is also made by the body. On average, we typically say about 30% of the cholesterol comes from food we eat and about 70% from what our body makes, but quite honestly, it's very individualistic. Cholesterol, our blood is mainly water and cholesterol is a fat. So fat doesn't mix with water. So our body carries cholesterol in lipoproteins. And there is one other type of fat in our body, which we'll talk about in just a second, called triglyceride. But cholesterol and triglycerides are very different. Next, please. So why should we worry about cholesterol? Well, for the lousy or bad cholesterol and for lipoprotein-A, that is the kind that can eventually cause these plaques in our arteries, leading to artery blockages. But HDL is our heavenly or healthy kind, and my patients like to call it heavenly or healthy rather than good or bad, because it helps them to remember which is which. So HDL is your vacuum cleaner. You want it scooping up a lot of cholesterol, so that's why you want the HDL cholesterol level to be high. Next, please. So here's a schematic of that. On the top slide, you see the bad cop laying down that LDL cholesterol in the arteries, and the good cop trying to carry it off as fast as they can. So that is the HDL. Now, the bad cholesterol, it's not just LDL. There's some other types of cholesterol, and all contain this specific protein that almost is the signature. It's like having a name on your jacket that says "I'm bad." So apolipoprotein B is a protein that all of these bad characters have. The LDL, there's something called remnant lipoproteins. Not on here is something called VLDL cholesterol, but all of these are included in this LDL cholesterol measurement. Next, please. Okay, so I taught chemistry at Texas A&M for a very long time, and I'm a professor by training, so I can't resist talking about the math behind a lipid panel. So lipid refers to the two fats in the blood, cholesterol and triglycerides. The total cholesterol includes the lousy cholesterol and the heavenly cholesterol, okay? But sometimes when you look at your lipid panel, okay, you'll see that if you mathematically add up the LDL and the HDL, it doesn't come up to that total cholesterol. Next, please. So here's the math, and this is actually what is done behind the scenes to report your lipid panel. So the total cholesterol is the heavenly or good cholesterol plus the lousy or lethal cholesterol plus all those other components I just sort of schematically indicated that are bad or a little bit bad. Very low density cholesterol, lipoprotein-A, and something called remnant cholesterol. So sometimes in your lab reports, you'll see something called non-HDL cholesterol. And I know a lot of providers that have trouble with this concept, but translating non-HDL cholesterol into English, it just means all the cholesterol that is not HDL, okay? So just like in a math class, if we rearrange that equation on the top line and bring that HDL, subtract that from the total, that is so the total cholesterol minus the HDL will give you everything that's not HDL, and essentially that is everything bad that can promote that plaque buildup. Next, please. Okay, I'm going to switch to triglycerides now. I told you that there are two fats in the blood, cholesterol and triglycerides. Triglyceride is very different from cholesterol, and a number of my patients will confuse the two of them and say I have high cholesterol when they really mean they have high triglycerides. Like cholesterol, we all need a little bit of triglycerides. Other than blood sugar or glucose, this is one of the fuels that our body runs on. There are genetic disorders where people have genetically high triglycerides, just like genetically high LDL cholesterol. But a lot of the triglycerides in many cases comes from our diet. And the main source in our diet is sugars and starches. Starches are potatoes, rice, pasta, bread, sort of everything white. Some of my patients say, oh, you mean everything good. I wish I meant to bring a soda bottle in here to show you how much sugar is actually in a 12-ounce bottle of soda, but it's about an inch full. The 12-ounce bottle of soda is about an inch full of sugar. And a lot of times people have high triglycerides from sugared beverages. It's not just sodas, but juices, frappuccinos, Kool-Aid, things like that. So really, the triglycerides don't directly cause that buildup of fat in the arteries, but they hang out with some bad risk factors like prediabetes or diabetes, or just a bad diet that can promote that buildup of fat in the arteries, that buildup of cholesterol in the arteries. Next, please. Okay, so not everything in a lipid panel is actually measured chemically in a lab. What's measured chemically in the lab is the total cholesterol. Can you tell I'm a chemist? It's the total cholesterol, the HDL cholesterol, and the triglyceride. Okay. Everything else we estimate. And the VLDL cholesterol is estimated by dividing the triglycerides by 5, but even a better way is something new called the Martin-Hopkins equation. In patients that have an elevated lipoprotein-A level, the LDL cholesterol is included in what we call LDL cholesterol. I'm going to say that a couple of times in the course of the next slide so you get the gist of it a little bit better. Next slide, please. Okay, so this is a schematic of these lipoproteins. So lipo, like liposuction, means fat suction, right? So this translates into a fat curing protein. If you took a very, very detailed microscopic picture of these lipoproteins, they actually do appear as tiny little spheres. And the spheres are covered by cholesterol, that's the yellow balls, by something called phospholipids, that's the blue balls. And then these squiggly things on the surface are actually the proteins that are that name badge, if you will, that tell us, is this an LDL protein or an HDL protein? So when you are told what your LDL cholesterol is, it's the cholesterol in that LDL particle, and the HDL cholesterol is the particle in the high density lipoprotein cholesterol. A lab can also tell you what your LDL triglyceride level is and your HDL triglyceride level, but it's not really very important. And by the way, in these particles, in these lipoprotein particles, the triglycerides are hidden more in the surface. Now, there are some other lipoproteins, and some of the advanced lipoprotein testing can discern those and measure, for example, the HDL triglyceride level. Next, please. Optimal levels. I mean, this changes almost every 5 or 10 years based on the evidence. But here's what we're going to go with today. The lousy or bad cholesterol should generally be lower than 100 milligrams per deciliter, but in people who already have a diagnosis of atherosclerotic cardiovascular disease, the lower the better, and there's nothing that's too low. The heavenly or good cholesterol should be above 50. Remember, that's your vacuum cleaner. You want it to be carrying away that cholesterol laid down by the LDL particle. And the other lipid, the triglyceride level, should be less than 150. Next slide, please. And by the way, one other caveat, levels for children, optimal levels for children are different than levels for adults. Okay, so when should cholesterol levels be checked? I'm a pediatrician. We know that if a child has a parent that has high cholesterol, or a parent or grandparent that's had premature cardiovascular disease, we start checking them anytime after the age of 2. And that's because if they have genetically high cholesterol, that's a common cause of having a parent with high cholesterol, or having a parent or a grandparent with premature cardiovascular disease, their cholesterol level is already reaching adult levels by the age of 2. That's when their liver is fully matured and making these lipoprotein particles. So quite honestly, the best time to check for familial hypercholesterolemia is actually between the age of 2, 3, or 4, before these children start to eat more of an adult high-fat diet. In children without that history, sometimes we really don't know the parent history or the family history very well. And so we know to check cholesterol levels. We're told to check cholesterol levels. The American Academy of Pediatrics suggests checking cholesterol levels in all children between the ages of 9 and 11. Now, it's kind of paradoxical in some ways that our adult guidelines say, okay, well, in adults, we should start checking cholesterol at the age of 20 and recheck every 5 years if it's normal, but more frequently if it's abnormal, and certainly if we're thinking about using cholesterol lowering medications. So really, we need people guidelines. We start checking cholesterol early, and we do it for important reasons: to create a family environment of healthy eating, and to use early medications if early initiation of cholesterol medications if needed. Next, please. Why do you need to be fasting for a lipid panel? Well, there's actually a movement that says we pretty much live more in a non-fasted state. So maybe non-fasting lipids are more reflective of our risk of having heart disease. But the main reason we do it right now is, remember I told you we estimate that VLDL cholesterol. We don't measure LDL. We use it, we estimate it. And part of that estimate is estimating the VLDL cholesterol, either by Martin Hopkins or the Friedewald equation, which is the triglyceride level divided by 5. And when you're not fasting, it's really the triglycerides that are substantially higher than the cholesterol level is. But it's because of that estimate that we have to do it fasting. If we measure LDL cholesterol directly, and there are tests that you can order to do that, then you don't have to be fasting. Next slide, please. As I alluded to, your cholesterol level may have changed, but the guidelines changed. So a man used to tell me, well, you told me my good cholesterol was just fine at 41. Yeah, but we changed the guidelines. Now it's the goalpost moved. It's now above 50. Next slide, please. This is a slide meant for professionals, and this is our pathway that we follow when we see patients that don't have cardiovascular disease and we want to know how to treat their lipids. That refers to primary prevention, okay? So you've never had a heart attack or stroke, we want to prevent one. Secondary prevention, we have a different algorithm, and secondary prevention means you do already have some type of cardiovascular disease, and we're trying to prevent another heart attack or another bypass, another stent, or another stroke. Primordial prevention actually refers to going back really when babies are in utero, and we're trying primordial prevention then. But I'm going to zero in on two things here, and I didn't circle it, but that upper right oval says if your LDL cholesterol is above 190, we go straight to therapy for that. A lot of providers will make a mistake and we have what's called a risk calculator. So a Framingham risk calculator or a pooled risk score to say, well, is there a risk of a heart attack? It's a crystal ball. Is there a risk of a heart attack high enough that we need to start a cholesterol medication? That does not apply to people that have presumed genetically high cholesterol, familial hypercholesterolemia, because they're not reflected in the big pool of people we use to formulate that equation. But let's focus in on this red box of risk enhancers. Next slide, please. So remember, I told you that there are major risk factors and minor risk factors. This is the minor risk factors in some ways fall under what is globally called risk enhancing factors. So, maybe it's not a major risk factor, but certainly we know that it accelerates or enhances the risk of risk factors that you have. So a family history of premature cardiovascular disease, and here we're black and white, men less than the age of 55 and women less than the age of 65 who have had stents, strokes, bypasses, whatever. But it's really a gray line. So if somebody tells me that their uncle had a heart attack at the age of 57, I'll probably lump that in as pretty much premature. Metabolic syndrome, we used to talk about this, syndrome X, it's associated with a little bit of waist fat, a slightly high triglyceride level, a slightly low HDL cholesterol level, or a slightly elevated blood sugar. And any three out of those make the diagnosis of syndrome X or metabolic syndrome. Chronic kidney disease. Sometimes you'll see on your lab reports that your estimated GFR is flagged, your estimated glomerular filtration rate, how fast the kidneys wash the everything out of the blood. Chronic inflammatory diseases, rheumatoid arthritis, lupus, all of these diseases here can accelerate the risk of heart disease. Next, please. Premature menopause sometimes is considered to be a risk enhancing factor, but several years ago, the American Heart Association actually said, well, pregnancy actually is sort of a stress test for women, and women that have a history of preeclampsia or even toxemia, that's very much like a positive stress test, because those women typically do go on to have more premature cardiovascular disease. Some races or ethnicities are associated with a higher risk with the risk factors we talked about. For example, South Asian people who live in who have South Asian ancestry. As I mentioned, there are other lipids or lipid biomarkers. We'll talk about a few of those. Sometimes you will have a high sensitivity C-reactive protein level measured. We started to believe more than a decade ago that inflammation in the heart arteries is the genesis of all evil. And this blood test called high sensitivity C-reactive protein, it measures that inflammation in the heart arteries. Actually, it measures head to toe inflammation. So we can't really have it be specific for the heart arteries, but it is a very good test in a population. We're going to talk about lipoprotein-A and ApoB here in just a second. ABI stands for ankle brachial artery indices. That's how fast the blood flows in your legs. That's the way you diagnose peripheral arterial disease. Next, please. Okay, so I promised you to explain what lipoprotein-A is. Next, please. Why is it the triple threat? Okay, it's the triple threat because it can cause thrombosis and cholesterol buildup and potentially impede the breakdown of blood clots in the arteries. So very complex looking cartoon here, but there is that LDL particle I showed you on a prior slide. Okay, now you get to see sort of interior to the particle, and you can see those triglycerides in there. You can see the free cholesterol, the FC, on the surface of the particle, and that squiggly line that was on the other schematic, that's this apolipoprotein B. That's that name badge for LDL that says, hi, I'm LDL cholesterol. But lipoprotein-A has a very, very unusual and massive protein attached to it called apolipoprotein-A. That's lipoprotein-A, okay? researchers talk about the number of kringles. That's the number of curlicues in this protein. It's almost like a ringlet, if you will, that's attached to the outside of this protein. And they call it a kringle because it looks like a Danish pastry called a kringle. Next, please. So everything in humans usually evolved for a good reason. And we think that lipoprotein-A evolved because it helped in wound healing. We were less likely to bleed to death if we had some lipoprotein-A. But conversely, when we don't bleed easily, we're more prone to form blood clots. That's thrombosis, which can cause heart attacks. It's a lousier type of the lousy cholesterol, so it really accelerates that buildup of fat in the arteries. But it also causes calcification in the arteries and heart valves, the aortic valve in particular. So the triple threat, I actually misspoke a little while ago. The triple threat is this calcific aortic valve disease. And it's thought that this calcification is due to some very mean characters in this lipoprotein that are called phospholipids, especially oxidized phospholipids. Next, please. The genetics of lipoprotein-A, more than 90% really seems to be explained about inheritance, and you can get a gene from each parent. You just like if you have familial hypercholesterolemia, the levels, adult levels, are reached by very early in life, 1 or 2 years of age, and increase up to about 5 years of age, and then probably stabilize. Although we don't have a huge amount of data to support these statements here, in part because decades ago when we first started studying lipoprotein-A, the tests were not as good as what we have today. So that's why sometimes you'll hear, oh no, it's not a risk factor. It is. Well, partly some people have said it's not a risk factor because we didn't have really good assays for lipoprotein-A in the past. So we had kind of dirty or not so good data. So levels really are fairly stable throughout the lifespan. You cannot actually influence the lipoprotein-A level. It is a protein level. It's not a cholesterol level. It does seem to vary a little bit with ethnicity, but not so much with age or gender. And although not on the slide, hint, hint, you really can't change it too much with diet or exercise. Sometimes a tip-off that people have an elevated lipoprotein-A level is that we think that estrogen can decrease lipoprotein-A. So after women go through menopause, their quote LDL cholesterol, remember that includes the lipoprotein-A cholesterol, can increase. And that may be a tip-off that they have an elevated lipoprotein-A protein level hiding under there. Next, please. I was very fortunate to be part of the National Lipid Association guidelines on lipoprotein-A. So this was a group of experts that did not include me, by the way. This was a group of experts that came together to formulate these statements. And it was truly just an incredible experience to be with these other physicians to help give some input into our guidelines. Next, please. So what we concluded, and by the way, that's a big A, that's a typo on the slide, that should be a small a. But due to lifelong exposure to lipoprotein-A, it is a risk factor, probably a major risk factor that can accelerate that buildup of plaque in the arteries and leading to premature cardiovascular disease in many cases. In children hardly ever have heart attacks, and they're usually never due to the common risk factors. But in children, one of the major risk factors for strokes, and strokes are about 1 in a million in children, but one of the main risk factors seems to possibly be an elevated lipoprotein-A level. But again, when something is 1 in a million occurrence, it's really hard to get data on it. Next, please. So I mentioned that lipoprotein A can cause thrombosis, and it is really, when you have a heart attack, it's not so much this very gradual, slow buildup of cholesterol in the arteries that causes the heart attack. It's actually due to what's called plaque rupture. And when the cholesterol leaks out of that deposit of cholesterol in the arteries, and the body sort of perceives that as a blood clot, a cut, so it rushes in to form a blood clot over it. And lipoprotein A may tend to, because of its thrombotic effects, we think, and not quite proven, but it may reduce how fast the body rushes in to dissolve that blood clot. Next, please. Okay, so I've talked about lipoprotein A and cholesterol, and it gets a little bit confusing. So we're going to think of these lipoprotein A, and you can just, Andrea, you can just sequence through these. We're going to think of these as, instead of spherical particles, we're going to think of these lipoproteins as buckets. And next, please. Each one of these buckets carries each one of these buckets comes in different sizes. And instead of talking about small, medium, or large, we talk about how dense or heavy they are, how quickly they would fall to the bottom of a test tube. So every lipoprotein bucket is filled with cholesterol, which is going to be cascading into the buckets as with the next advancement, and triglycerides. Okay, so here comes all these lipids filling up these buckets. And as I mentioned to you, when I tell you what your LDL cholesterol is, it's the amount of cholesterol in the LDL buckets. HDL cholesterol is the amount of cholesterol in the HDL buckets. And the lipoprotein A level is actually the number of buckets. Apolipoprotein B is the number of LDL buckets. Next, please. Advance, please. So in the lab, we can't measure the cholesterol in the lipoprotein A particle. That would require advanced lipoprotein testing. So in the lab, what in your report, it just has LDL cholesterol, and that's going to include the cholesterol in the lipoprotein A bucket. The number of buckets is what is measured as the lipoprotein A level. Okay, and continue to advance, please, Andrea. Okay, and then here we go. There's that non-HDL cholesterol. Okay, so everything that is not HDL. Next, please. Okay, so if your lipoprotein A level is 124, that's the number of buckets. The cholesterol carried by lipoprotein A is included in the LDL cholesterol. But it's a real misnomer. It's really LDL cholesterol plus lipoprotein A. Next, please. Okay, how do you tell the difference between good and bad cholesterol? Sometimes it's kind of hard, but this doctor says that bad cholesterol has an evil laugh. Next, please. What are the treatments for lipoprotein A? Next, please. I used to be a big user of niacin. We know that it actually decreases the lipoprotein A level, but rather paradoxically, and also niacin I use to raise the HDL, but paradoxically, we know from really well done studies that it doesn't decrease the risk of heart attacks and strokes. So that's kind of like, covering up cracks on the wall. We think we're doing well by reducing the protein level, but the meaningful outcome is, does it decrease our risk of heart attacks and strokes? And niacin doesn't, so we don't use it really anymore. High dose statins in any dose, but especially in high dose, if there is an elevated lipoprotein A, can decrease our risk of heart attacks and strokes. It really doesn't change the lipoprotein A, the number of lipoprotein A buckets, but it certainly decreases the LDL cholesterol. These new injectable cholesterol medications called PCSK9 inhibitors, you know them by their trade names, Repatha and Praluent, may decrease lipoprotein A. We don't quite know the mechanism yet, but certainly they decrease our risk of heart attacks or stroke. In severe cases, sort of a lipid dialysis, if you will, called apheresis is used to remove the ApoB containing lipoproteins. And remember, I told you that schematic of lipoprotein A, it had ApoB on it, that signature name tag for LDL, as well as as well as apolipoprotein-A. So apheresis removes both lipoprotein-A and LDL and is used in the very severest of cases. There are actually some exciting new drugs on the market that can actually decrease the lipoprotein-A level, and these are in clinical trials now. Next, please. So if you were a group of doctors, we're always asked to give a case presentation. And so I'm going to go through this case presentation, and I'm going to, some of the terms in here are medical terms, but we'll just go through this very quickly. So this is a 42-year-old police officer. By the way, first responders have a markedly increased risk of heart attacks. So he's referred to me to evaluate his high lipid levels. He doesn't have any chest pain symptoms. He has a pretty good exercise tolerance because he has to undergo periodic exercise tests, okay? He has high HTN, is hypertension, high blood pressure. He doesn't smoke, but he uses snuff. I'm here in Texas. His mom had premature cardiovascular disease. She had a stent at age 62. She's doing well. He thinks she has high cholesterol. His dad has type 2 diabetes. His sister is healthy, but she had gestational diabetes, and he has 2 teenage kids. So his blood pressure is a little bit elevated. A great blood pressure would be below 120 and below 80. So his is elevated. His body mass index, his weight adjusted for height is 32. Above 30 means he's medically obese, and he has a little bit of a heart murmur. His thyroid function, his kidney function, his liver function were all normal. Next, please. So here are his labs. His hemoglobin A1C, I'm not going to explain that, but that's a measure of diabetes, was in the pre-diabetic range. He had an elevated lipoprotein-A level. He had an elevated total cholesterol. His HDL is a little low. Remember, that should be above 50. His triglycerides were okay, below 150. And so I now know that because I got a lipoprotein-A level, that what we call that LDL cholesterol really includes this lipoprotein-A level, and that was high at 192. Okay, if you subtract 42 from the total, you're going to get 219, and there's that non-HDL cholesterol. I ordered a coronary artery calcium score in him. That is a CAT scan that can look at for hardening of the arteries, and it's some of our guidelines recommend we do that if we're trying to decide on whether or not to put a person on cholesterol medications. He really wasn't too keen about the idea, and he had a lot of calcium buildup in his arteries. I got an ultrasound of his heart, an echocardiogram, and indeed he had some early calcific aortic valve stenosis, probably associated with that lipoprotein-A. And then per our guidelines, I screened the family members for both an elevated LDL and a lipoprotein-A. And his children and his mom both had elevated lipoprotein-A levels. Next, please. So I started him on rosuvastatin. His LDL cholesterol went down nicely. I added ezetimibe. That decreases the cholesterol level absorbed from food you eat, and we got below that nice value of 100. Because he does have actually subclinical coronary artery disease. He has hardening of the arteries. I started him on baby aspirin. Of course, I have worked with a wonderful dietitian, referred him to him, and his children were referred to a pediatric lipid specialist. That happened to be me in this case. Next, please. Okay, so key points for lipoprotein-A. It is included in the LDL cholesterol level. We screen for it to improve sort of an assay of our risk assessment. If it's elevated, we need to screen family members. And actually, the first therapy we reach for these days is a cholesterol-lowering medication, a statin, cholesterol absorption inhibitor, secondarily, ezetimibe. And then maybe if this patient has a real high risk of heart disease or strokes, one of the newer agents, the PCSK9, and probably in the future, one of these very specific lipoprotein-A drugs. Next, please, lipoprotein-A lowering drugs. Sometimes physicians order what's called an advanced lipoprotein analysis. Now, I was very privileged to work with a lab that developed one of these tests, and they're really amazing for the information they cover. But I'll just say that really no professional guideline currently recommends advanced lipoprotein analyses over a regular lipid panel. So you may hear about NMR lipoprotein testing. That tells us how many lipid particles there are and the size. Sometimes I will actually order what's called a lipoprotein metabolism profile because it tells me a little bit about rare cholesterol disorders. And just like the lipoprotein A level is the number of lipoprotein A particles, apolipoprotein B is the number of LDL particles. Next, please. I think that brings us to the end. Okay, so let's see if I educated people.
Yes, thank you so much. That was great. Lots of information to unpack there. So now we're going to do our poll again to see if we learned about what the lipoprotein A is. And so I am going to launch the poll again and ask everyone to take their poll. And then Mandy, I'd love to hear from you a little bit about maybe your journey, maybe what your take on all of this information is. Let's start to unpack it. In the meantime, two things. Put your question and answers into the chat, into the Q&A or the questions, and I will get to them if we have time. And the second thing is we do have a great handout that is in the chat box. You can download it. It will be sent out with the YouTube link after the webinar as well. But let's check our poll. We're going to give one more second.
Hello.
And we're going to go ahead and share the results of this.
Okay, so I'm really encouraged that nobody says they don't know what lipoprotein A is. Now, in all fairness, and I should have had it on the slide and I didn't, that was a test. Were you listening to me or just reading the slides? Lipoprotein A is really not affected by the diet. You can, I'll give you a little bit. The lipoprotein A protein level is not affected by the diet. Certainly you can reduce the LDL cholesterol by your diet. So it's we could finesse that question a little bit, and it's definitely not the good cholesterol. That was just a typo.
Great, thank you. So I'm going to go ahead and launch this poll. And Mandy, are you with us still?
Yes, can you hear me okay, Andrea?
I can.
Great. That was a wonderful presentation, Dr. McNeil. There was so much information. I'm going to need to go back and review it all, but there was a lot. I guess just to quickly share my I have two boys, and they were diagnosed pretty young with high cholesterol. My oldest, his cholesterol levels were elevated by 7 or 8. He's 16 now, and my 13-year-old has also different years had higher cholesterol levels too. And my oldest, it's been a little more manageable. The levels have been less alarming the past few years, and it's definitely hereditary. Their dad is in excellent shape, eats very well, and he still needs to be on a statin. Their paternal grandfather had a stroke also. He's fine, but also the same type of cholesterol issues. And so I guess my concern is, at what point do you need to turn your children over from just a regular pediatrician to a lipid specialist? And then also, I think one of my big takeaways from this is that it's maybe not just the LDL, it could be the lipid protein A. And I need to be taking a closer look at their panels and asking more specific questions from their pediatrician when they get their annual cholesterol evaluation.
So Mandy, first of all, I may have missed it. Do you have an elevated lipoprotein A level?
No, my cholesterol levels are fine. I have no issues, but their dad does. So it's all on the
Okay,
paternal
so
side.
just remember, so a lipoprotein A is not going to be included in a standard lipid panel. That's an extra test. But you
It's an
raise a
extra test.
really great question, what do you need to do with the kids? And so, and when do you need to turn them over to a specialist? Some pediatricians are comfortable with lipid management. Some say I can manage, the diet and their exercise. But if we're talking about starting them on cholesterol lowering medication, I'm not comfortable with that. And that's probably when they might say, maybe we should have a specialist weigh in on that. So I guess that's a question. And then, okay, so does my child need to be on a cholesterol lowering medication? Our guidelines are black and white. If the child's LDL cholesterol is above 190, yeah, because they possibly have heterozygous familial hypercholesterolemia, genetically high cholesterol. It's been high since they were about 2. Most people cannot eat themselves, and certainly a child really can't eat themselves to an LDL cholesterol, an LDL, not a total or a triglyceride, but an LDL cholesterol of 190. And, I see patients, adults that are so frustrated because they can't change it with diet. Well, yeah, you can eat air and water. And if you have genetically high cholesterol, your LDL is probably still going to be elevated. Not as bad as if you eat fatty food, but it's still going to be high. So with children, we don't differentiate by gender as we do with adults to some extent, although not with FH, we certainly don't. But I drag my heels a little bit with young girls because we're not supposed to use statins in pregnancy and in young girls who may be at risk for getting pregnant, teenage girls that may be at risk for getting pregnant, I'm a little bit less likely to use a statin. But statins, one of the ways I get my adults to sometimes take a statin is to tell them, hey, these drugs have been approved in children since the 1990s. We have pretty doggone good safety data in children, no new emerging safety concerns. And so in Europe, some of the statins are approved down to age 6. In the US, they're pretty much all approved down to age 10. Why would we even think of starting a statin in childhood? Remember that schematic, the artery I showed you? We think if there's no other risk factors that are acquired, that artery can stay pristine clean for the rest of their life on statin therapy. So this is a great genetic disease if you have to have one, because we already have a phenomenally good cure for the disease. Mandy, did I answer your questions? I sometimes go off track.
You did. That's so encouraging to think of their little being clean and clear if they for decades. Because you hate to think about that in your children, them getting all clogged up early on. So
yeah, and the reason for testing at age 2, okay, is not to say we're going to start cholesterol medications at age 2, but if a parent knows their child has high cholesterol, the earlier they know that, I would say the better they're going to structure their environment. Children's diets are pretty much entrenched by the ages of 8, 9, 10, 11. And so it's only our eating habits that we project to them. So if we don't eat fruits and vegetables, if we like to go out and eat hamburgers and fries, our children are going to like that too. But I'd like to think that if a parent knows their child has high cholesterol, that the family nutrition is going to be really great, and they're not going to let the child get large thumb muscles. They're going to make them go out and play.
Definitely. I've been pushing the olive oil for a long time.
I always tell when I see kids with high cholesterol, I ask them if they smoke, and they kind of look at me like I'm a little bit crazy. But honestly, many adults start when they're like 15 or 16, and they'll tell me no. And say, great, that's good, because I just want you to know and remember one thing: if you ever do start, I'll hunt you down and kill you.
Great. So we just have just another minute or two for a couple of questions I'd like to get to. We have a bunch of questions in the Q&A. If we aren't able to answer your question now, we will follow up with answers to the questions. We work really closely to make sure that everybody's questions are answered. So the first question, and I think they kind of go together, so I'm going to kind of bulk them together. Shouldn't we be measuring ApoB and ApoA1? And then why is the LPA not on the lipid panel?
So those are great questions. So, you know, there's a lot of scientific argument and discourse. So ApoA1 is that signature for the good cholesterol, HDL. ApoB is the signature for the bad cholesterol. Remember, a lipid panel is just total cholesterol and triglycerides, okay? And that's what we knew back 50, 60, 70, 80 years ago when we started measuring lipid panel. So this is classic. And so ApoB, ApoA1, and lipoprotein-A are add-on tests. It's not a cholesterol level. These are protein levels. Okay, so we're not going to be measuring protein levels in a lipid panel that is looking at lipid levels. And so some people think that those lipoproteins, the ApoA1 and the ApoB, are better markers of risk than just an HDL cholesterol or an LDL cholesterol. There's a lot of argument about that. They're also very costly tests compared to a lipid panel.
Great. And then final question, because it is 1 minute after, and I'm so sorry. Thank you all for hanging in there. All statins increase LPA. It gives the reference. It says the use of a statin in very elevated LPA may not reduce risk, rather it may increase it. Can you comment on that?
Sure, really great question. Now I'll just say that, you know, we have to have really large numbers to know that. And, you know, I'm not sure we have great evidence that shows that statins include the lipoprotein-A, that they elevate the lipoprotein-A protein level. Remember, that's genetically programmed. So it'd be hard to imagine that the statins are changing our genes to increase the lipoprotein-A protein production. The National Lipid Association and all professional guidelines are very clear to decrease cardiovascular risk. Even if the cholesterol, the LDL cholesterol, is not high, statins can decrease that cardiovascular risk. And remember, the lipoprotein-A cholesterol is included in the LDL cholesterol. So when you start a statin, the classic cholesterol lowering medication, it decreases LDL cholesterol. It probably does not decrease lipoprotein-A cholesterol, but it certainly decreases risk by very definitely bringing down the LDL cholesterol.
Great. Well, thank you so much for such an engaging and interesting conversation. We appreciate your time. Mandy, we appreciate your time. And for everybody else, make sure you join us for the next session of the series. It is next Tuesday, April 13th at 3 o'clock, same place, same time. Make sure you're registered. And we will be sending out the link to the webinar recording and also the handout for the webinar within the next day or so. So Dr. McNeil and Mandy, thank you so much for joining us, and everyone have a great day.
Thank you, Andrea. Happy to answer all the questions.
Thank
Bye-bye.
Yeah.